Good afternoon, everybody, and welcome to the webinar. We are in our clinical trial education series. We are in session number 3, and today we are joined by Megan Collerite, who is going to share with us about shared decision-making and informed consent. And we're so excited for her to be here with us. Before we get started, I just want to give you all a couple of updates. Please enter your questions into the Q&A box, and we will moderate those questions out to Dr. Collerite at the end of the presentation. You do not have to wait till the end to put your question in those, so add them as you're going. And also, as a note, Dr. Collerite will not be able to answer questions directly related to your care because she's not your treating physician. But I am going to turn this over to Megan, and thank you, Dr. Collerite, for being here with us.
Well, thank you for the invitation. I'm excited to share more news about shared decision-making as one of our best practices in patient-physician communication. And I really look forward to the discussion because the input of patients as experts is most important. So we'll talk about shared decision-making right from the beginning and how it applies to heart disease. And I'll share a little bit about how it is different from, although related, to informed consent. So I am an interventional cardiologist and the director of the structural heart program and vice chief of cardiology at Erlanger Heart and Lung down in Chattanooga, Tennessee. These are my conflicts of interest. When we're talking about shared decision-making, we're really talking about a very specific area of medicine, and that is when there are more than one reasonable options that patients are considering. Sometimes in medicine, the weight of the evidence clearly favors one option over the other. And when that occurs, clinicians make a recommendation, a strong recommendation. But there are many times in heart disease, as well as in clinical trials, when there are more than one reasonable options, and there is uncertainty in the evidence. That is, there isn't a clear path on which one is better. Preference-sensitive decisions are made up of these two components, in addition to when patients may vary in how they value the risks and benefits, the differences of the two choices. And patients might vary based on where they live, their race, class, gender, the role in their community and their family. They might see the decision differently. And that's certainly an area when we need to invoke shared decision-making. And finally, it's really important when patient preferences may be different than physician preferences. And sometimes there is a disconnect with regards to physicians' understanding that that may be the case. And that's where shared decision-making is critically important. There is a lot of push for shared decision-making, but we'll talk about how it still hasn't translated very well into clinical practice, specifically in cardiology. Medicare actually mandates a shared decision-making approach for a few decisions. Now, we don't often think about Medicare controlling or defining or delineating the physician's behavior, but in this case of left atrial appendage closure, they did. They said to physicians, if you want to provide left atrial appendage closure for stroke prevention, that's when we put a small plug in the left atrial appendage to reduce the risk of stroke, then you do need to go through a shared decision-making process. And they highlighted that that needs to happen with an evidence-based decision aid. Well, there's not a lot of understanding about what a decision aid is amongst physicians, and we'll talk more about that with examples. And the final criteria for Medicare was that physicians needed to document this in the medical record. So a formal shared decision-making interaction, specifically on the choice of blood thinner or not taking a blood thinner for stroke prevention and AFib, with an independent non-interventional physician using an evidence-based tool. This was very controversial, as you might imagine, amongst physicians. Here's an example of a decision aid that we have recently published on in Circulation Quality and Outcomes for this decision. So just as an example, this is embedded in the electronic medical record in Epic. And this particular tool pulls information from the patient's electronic medical record to display their personalized risk of stroke and their personalized risk of bleeding. And then you can see at the top of the decision aid are the choices that are available to patients with regards to reducing their risk of stroke. They could be on no medication or an anticoagulant, or consider Watchman, which is a device to close the left atrial appendage. And by selecting the varying options, patients and their physicians can talk about the risk reduction with each and the potential harms to make a decision together. So this is an example of an evidence-based, personalized decision aid that can be deployed at point of care and that would meet Medicare requirements and potentially align the patient's decision with their goals and preferences. Here's a screenshot showing if the patient chose rivaroxaban or Xarelto, a blood thinner to reduce the risk of stroke in AFib, we can model for the patient that of the original 19 men out of 100 that would have a stroke in the next year, all the men in circles, 13, would avoid a stroke if they took Xarelto. There still are men at risk for stroke, 6 in this case. And we talk about how that's because not all strokes come from the left atrial appendage. Some come from the carotid arteries, for example. So we spend some time talking about risk reduction with the therapy that's chosen. And then we turn our attention to potential harms. 1 out of 100 men would have a serious bleeding event because of the Xarelto. And then we can engage in what's most important to patients. So this is an example of shared decision-making. You might also think of this as an informed consent for, say, Watchman. Now, only in one state in Washington can shared decision-making with decision aids take place of informed consent. In most states, they are separate activities. And certainly those that are passionate about shared decision-making worry that perhaps if we mandate shared decision-making, it will become a checkbox, like many activities of informed consent have become. And we certainly want to delineate this is different because it involves a discussion, that we haven't made a choice yet. We're not just going forward to saying, yes, I already decided on surgery and I give my permission, but we're trying to understand how to make that decision with patients. So another decision that has Medicare's interest is the decision of how to prevent sudden cardiac death. So for patients who have a low heart function, like a low ejection fraction, they may be a candidate for an implantable cardioverter defibrillator, or ICD. Medicare did mandate a shared decision-making approach when thinking about an ICD and said that if physicians want to be able to deliver this therapy, then they need to engage patients in the decision, because this is one in which there is uncertainty in the evidence, and that is how it helps patients who perhaps have very few symptoms, because many of the trials included patients with a lot of symptoms, and patients may differ in how they weigh the risks and benefits. So I'm showing another example of a decision aid. This one has more information about the disease process and the device itself up front, but later goes on to show some of those individualized risk estimates. Both of these are designed to be read and consumed by patients, although some decision aids are really read before the visit, and then the patient comes and talks to the doctor. And then others, like the one I showed you before this, are really gone through with the patient and doctor during the visit. One more example of a decision in which we really focus on shared decision-making is the treatment of heart valve disease. So in this case, aortic stenosis, which is a very tight valve that doesn't open well, these patients can be offered either a minimally invasive procedure called TAVR, or transcatheter aortic valve replacement, or a surgical aortic valve replacement. And for many patients, it's a difficult decision. There may be some uncertainty in the evidence, such as how long the valve will last, as well as potential risks of the procedure, like need for pacemaker. And also, patients may really differ from one another and from their clinicians about how they think about that recovery period, their roles and responsibilities with their families, for example, perhaps if they're caregivers. So it is an important decision to engage with patients. Notably, Medicare did not mandate shared decision-making in their most recent approval of TAVR, in part because they said there weren't enough decision aids available, and also in part because we've seen for those other two, left atrial appendage closure and ICDs, implementation of decision aid use in clinics has been really hard. That is, getting physicians to actually use the tools and have the conversations. So that's been more of a focus. The mandate didn't lead to that as much as Medicare would have hoped it would have. So shared decision-making, really to summarize, is a meeting of two experts. It's when you have a physician who understands the choices available and the risks and benefits of those choices, and then you have a patient as expert in what's most important to them. So in this schematic, we have a patient saying, what matters most to me is, and the physician is reflecting back, what I'm hearing you say is, and that confirmation of really listening to patient goals and preferences is the focus of shared decision-making. More research is going on right now by my own research lab about how to prepare patients for that discussion. They might not be ready to show up at the visit and say, what matters most to me is, so we're developing some tools with patients to understand what was most important to them in their decision-making process as they went through, in this case, aortic valve replacement. So sometimes the tools that are needed are not just for the decision, but also to clarify what's important to patients. So the process of shared decision-making is a 5-part process. These are the slides we use when we teach physicians how to do the process. And most physicians think they already do this perfectly. But when we go through training, they begin to understand pieces that have been missing. Oftentimes they do name the choices available, although sometimes we've recorded through surveys that patients leave a visit and had no idea a choice was being made that day. So naming the choices is the first step. The second step is explaining shared decision-making. For most patients, if we say, which one do you want? A transcatheter valve or surgical valve? They say, I didn't go to medical school. I can't decide. You decide, doc. But when we explain to patients, it's not that you have to make the decision on your own or make a technical decision. What I need to know is what you're expert in. What's most important to you? What are you hoping to achieve with this therapy? And then we can help align your goals with the choice. Step 3 is to describe the choices using an evidence-based decision aid. Many folks, patients, even physicians are really visual learners. And to have all of the conversation verbally makes it very difficult to participate. So using decision aids so that we can display information using pictographs as well as easy to read language that's been tested with patients is really important. Here's another example of a decision aid, this time for the treatment of aortic stenosis. We're comparing palliative care or medical management with transcatheter aortic valve replacement. This is for patients who are really elderly and have many other health conditions that might limit their ability to benefit from a transcatheter valve replacement. And so we're showing in blue the option of symptom management and in orange the option of valve replacement. And right below that, as we're talking about will they feel better and what they'll need to go through, is a box that is indicating the important part of the conversation. What matters most to you? Sometimes when I talk to people about this decision, for example, they say that avoiding any invasive procedures or time in the hospital is most important to them. Other times they say that having a quick recovery and feeling better, even if they have a high risk during the procedure, is what's most important. And then at the right side, we show some personalized risk. Sometimes decision aids are a little bit tricky to understand who's the source. Who are the people that author the decision aid? And so that's why understanding where all the options are for looking for information about your disease condition are important. This particular decision aid, for example, at newheartvalve.com is authored by Edwards Life Sciences, which is a company that makes both surgical and transcatheter aortic valves. So certainly moving us towards the decision to undergo a procedure. And there is a lot of good information on the industry websites. We just need to understand who's doing the writing in those cases. The decision aid I showed you earlier is from a website called CardioSmart. This is an organization or a website from the organization, the American College of Cardiology, or ACC. It is an excellent source of information for patients with heart disease. And we are starting to offer more and more decision aids on this site. So certainly something to get caught up on. And then there are additional decision aids, this one for aortic stenosis, that may come out of government-sponsored research studies like the NIH, as this one did for advice. So we're developing more and more tools that can be tested and used in the encounter. So the first 3 steps in a shared decision-making discussion are for physicians to name the choices, explain the role of the patient and the physician, so patients are welcome to be included, and describe the choices using a decision aid. The 4th step is to listen to what matters most to the patient. When we do research on shared decision-making, and we audio or videotape clinical encounters with decision aids, step 4 is what's missing most often. Physicians will often say things like, do you have any questions or do you agree? But not necessarily being savvy about how to elicit what's important to their patients. And the 5th step is to make a decision together, incorporating the patient preferences into that decision. When we use decision aids in a shared decision-making approach, patient outcomes are improved. Now, some people say this is kind of a soft science. We're just trying to talk about how to be nice to folks. This is over 100 randomized controlled trials of decision aids showing improvements in patient involvement and knowledge, a very small increase in visit time, as physicians are worried this will take too much of their office time. And we see a reduction in decisional conflict. That's a measure where we're looking to see, does the patient's decision match with their values and preferences? So we see that more often with the use of decision aids. And we also see a reduction in the number of patients that are undecided. They come out of the visit knowing that the decision is made and that it matches with what's important to them. I can't say that we have research proof showing that decision aids steer patients towards one decision or another, that it improves medication adherence or reduces costs. These are all things that have been described as being hoped for with shared decision-making, but we haven't proven that to be the case. But I think the gold standard is that we show that the decisions are more aligned with what's important to patients. So why isn't this used all the time? Well, we have well-defined barriers to implementation, and I bet during the discussion, some folks will write in and say that they understand what some of the barriers are for their own physicians that they've worked with. The number one barrier to implementation are physician attitudes and skill sets. They've been found to be minimally present in clinical practice, although physicians often feel that they do have the skill sets needed. Also, there are real biases about which patients want to be involved. Patients often in surveys say that they want more engagement than they're getting, but the physicians have the perception that my patients actually don't want to be involved. They just want me to tell them what to do. So there's certainly miscommunication between what patients want and what they're receiving. Some of the barriers are effective, tested, and acceptable decision aids. Not only do they have to be shown to be helpful, but also physicians have to perceive them to be helpful to use them. Physicians always worry about whether this will take too much time. And then ultimately, one of the barriers is policy. We need physicians to be reimbursed for this very important task. One of the other primary barriers when we think about shared decision-making is that there is a misconception that informed consent is equal to shared decision-making. So in informed consent, you have a one-way stream of information. We are imparting knowledge on our patients. We want our patients to know what the risks and benefits are. So we tell them a stream of information. But when we don't have that second piece where we're listening to what's most important, then we do not have a shared decision-making process. So many studies at the beginning said, if only patients are knowledgeable, if we give them a whole bunch of information before they come to the clinical encounter, let them read a bunch of pamphlets, have them undergo a lot of education, maybe through videos or visits with nurses, and then when they come sit down with their physician, then shared decision-making can occur. It was just that patients didn't understand the complexities of the decision. And what this systematic review found is that knowledge is not power for patients. When patients walk into a room, there's an immediate power differential between their physician and themselves, in part because they're seeking care for being ill or for having a health problem. And so they're immediately vulnerable. And we find that knowledge is not enough. There needs to be perceived permission to participate. And that's that invitation, the definition of shared decision-making with patients. Let's go through a couple examples where shared decision-making can be helpful. We'll get to some of the disease conditions that are familiar to the audience. So this is an example of a patient of mine who was a 55-year-old farmer. I met him during my fellowship in Minnesota. He had a history of hypertension and was on losartan, and he had angina. He had angina just with really limited activities, just doing the basic chores around the farm. He underwent an exercise echo stress test. So he had got up on a treadmill, exercised, and laid down really quickly and had an ultrasound put on his chest. And what they found was that his heart function was normal, but that he did have areas of the heart that didn't move as well after exercise. So there was the thought that he probably had a blocked blood vessel. He he was referred for a cardiac catheterization. Now, the question is, when I'm talking to this patient, which options do I offer? Do I offer him optimal medical therapy if he wasn't on an aspirin or a statin or a beta blocker like metoprolol? Should we offer that? Or should we go right to optimal medical therapy and PCI, a stent? PCI stands for percutaneous coronary intervention. So that's when we go up through the blood vessel with a small tube and put a small metal scaffolding in to open up a blocked artery. Which options do we offer to the patient? Well, in this case, I utilized a decision aid for the treatment of angina. And this tool describes that the choices available are medications alone versus medicines plus stent. Most patients have the misconception in the context of stable angina. We're not talking about a heart attack, but where you have the same amount of chest pain every time you do something that goes away with rest, that stents are going to save their lives. We have not shown that. We've shown that there's less angina, that it makes people feel better. But when I talked with this farmer, he said, of course I have to have a stent. I don't want to have a heart attack. Well, medications are the way to reduce the risk of heart attack. So we had to move through those misconceptions, and I needed to understand what was most important to him. We first highlighted the benefits of stents in stable angina. No difference in heart attack or death, but symptoms improve faster with stents. By 1 year, the two groups are very similar. And then we go over the risks, the risk of the procedure, the risk of taking aspirin and Plavix, for example, the blood thinners that are needed for stents. So if we ask the patient right up front, which choice is important to you, he might say, you decide, or I want a stent. But when more information is delivered, we can make sure that the choice is aligned with his values and preferences. So let me go back to that decision aid and tell the story of this farmer. What was most important to him? Well, it was almost time for harvest. He did not want to wait 1 year to feel better. He needed to have angina relief immediately. And once he understood that it wasn't going to reduce the risk of heart attack or death, he still selected a stent because of the need for that physical activity right away. But when I did the procedure, I knew we were doing it for the right reasons that would match with what was important to him. There are many myths about shared decision-making, and this actually leads to a reduction in implementation. These are myths that physicians will often tell me when I present on shared decision-making about what they're concerned about. First of all, they say, shared decision-making is actually when I talk with another doctor, they agree with me that we should go forward with the procedure, and then we make a recommendation. Like in treating valve disease, the interventional cardiologist and the cardiac surgeon, they get together, they talk their shared decision-making, not acknowledging that the patient is not in the room for that decision. Some physicians say that's impossible. Patients always ask me what I would do. If I were your parent, what would you do? That is a very common question, but I would counter that to say they're not actually asking what I would do for my parent. They're asking me to know them like I know my parent, to understand what's important to them, to their roles in their family and their community, to their history in order to provide a recommendation. That's a very different question, and it requires a bit more work. Some physicians think they already do it perfectly, and others think, just give them a pamphlet and then we'll be good to go. But I think you've seen from this talk so far that there are a few more steps in between. Shared decision-making is different from patient education or informed consent. The first step is that knowledge transfer, and that's really what patient education and informed consent is. But the second step is listening to patient preferences. Then we can deliberate together and come to consensus on a decision that matches with the patient's goals and preferences. Let's look at it another way, just to hit home these main points. This is actually a way to think about shared decision-making that has 3 different steps. First of all, you have on the left side, the patient comes in with some initial preferences. They might come in and say, I definitely don't want a stent, or I definitely want TAVR, or I definitely want to stay on my blood thinners. They have some initial thoughts from talking to their families or neighbors. Maybe they saw commercials that influenced them or reading something on the internet. So the first step is to talk about the choices, the physician to outline what are the appropriate options for the patient, and then get into those options. So talk about risks, benefits, the differences between them, and then deliberate. And during that deliberation, that's where we need decision support. We need tools that patients can understand. We need videos that provide patient examples. We need a lot of support during that time. And then we make a decision together, making sure that what's important to the patient is included. I'm going to skip past some of the data on some of the decision aids, but I just want to highlight a call to action for Mended Hearts and its members. And that is that we have a long way to go for implementation of decision aids to support shared decision making. This important study looking at implementing shared decision making in valvular heart disease found that at Mass General, where they do have decision aids available for many decisions, they distributed nearly 10,000 decision aids in 1 year, and only 24 were for cardiology. So who are the fields that are leading? Oncology and orthopedics. They have really blazed the trail for engaging patients in decisions, educating patients, but then being able to elicit their values and preferences. So we do have some role models to follow in cardiology. The other important piece of information to know is that sometimes patient-defined goals are different from what we've measured in clinical trials. And this is where the engagement of patients in clinical trials is so important. So when I sit down to talk to a patient about the options, I'm giving them information that I learned from clinical trials. But the outcomes in clinical trials are usually not picked by patients. They're picked by researchers and physicians. Patients have not traditionally been involved in the shaping of how we measure success. And so we do need to understand how patients think about that. So we did, an early study where we looked at patient-defined goals for the treatment of aortic stenosis. And what we found in that study was that patients weren't thinking about necessarily lengthening their life. They were thinking about quality of life. And specifically, they were defining that as the ability to do an activity that was important to them, to get down on the floor with their grandkids, for example, or the ability to have a hobby that they loved continue, like working in the garden. We weren't measuring the ability to do those things. We just were looking if patients lived or died or had a stroke or not. That doesn't necessarily speak to the quality of life that was important to patients. So that's the next step in shared decision making. We're at the stage where we're making a decision based on the information available from clinical trials that are in the decision aids. We need to take some steps way back to the beginning to get engaged in clinical trial design so that we ensure that what's being measured when we are testing heart therapies is what's most important to patients. Well, I'll pause there. I hope that you've had a good summary of what shared decision making is, how it differs from informed consent and patient education. And I would love to open up a discussion and take your questions.
Great. Thank you so much. That was some great information. So I have about 5 questions so far. If anybody has questions at 6, please put them into the chat. We would love, or into the Q&A. I'd love to send them out to you. The first one says, how does a patient initiate a shared decision process like this with their doctor? How do we know they're open to it or practice this way? And will they be annoyed if they're too busy for this dialogue?
What a fantastic question. And part of that gets at the question, whose responsibility is it to open a shared decision-making discussion? And I think we can all agree it is the clinician's responsibility. But then you might say, okay, fine, but what if my clinician isn't opening up the discussion? Can I engage with them in shared decision-making? And I think that that is something that each individual patient is going to need to decide for themselves about their own comfort level. If you bring up shared decision-making with your physician, or even bring a decision aid, say from CardioSmart, you might be educating your physician about what shared decision-making is. They may not have heard of it, or they may have those misconceptions. Remember that we went over together, that they're already doing shared decision-making, even though they didn't ask you about what your goals and preferences are. So I do think that it is reasonable to try. I have heard from many patients that they worry about being branded as a difficult patient if they're challenging the direction that the clinician wants the visit to go. And I think that we can all agree, if that's the case, then it may not be the greatest partnership with that particular physician. And perhaps meeting with another physician that might be open to the process would be a better fit for you. But there's not one right answer. There are many reasons why we choose one particular clinician to take care of us. But I would urge just a little bit to open up the conversation and say, I've heard a lot about shared decision making, and I think it would be something that would really benefit this decision. What are your thoughts about that?
So on that note, do you think that that is the same with all of the care, not just in a clinical trial setting, but if you are if you're in the hospital or your loved one is in the hospital and they say, we're going to replace your valve, is it appropriate for you to say, can we discuss all of the options?
Mm-hmm. I do think that that's very appropriate. I think shared decision making is most appropriate when there are two options or more that are both reasonable alternatives, but there may be some uncertainty in the evidence about how they're going to benefit a person, or if the person's values and preferences might differ from that of other patients or of the physician themselves. That would be a marker that shared decision making was appropriate. I'll give an example where it would be less appropriate, for example. So I'm an interventional cardiologist and I take care of patients that have heart attacks. And if I have a 55-year-old farmer come in and he's in the midst of a severe heart attack, I don't necessarily say, there are more than one option. We're not sure about the evidence. Here's a decision aid. I say, there's one option here that is clearly outweighing the risks of any of the other options. And almost every single patient would feel that this was the way to go. So let's move forward. My recommendation is open the blocked artery. And I think most patients in that scenario are like, yeah, let's go. But if there is one clear right answer, the thing is that medicine is changing. There are so many options now. There are very few situations where that is the case. Some emergency situations and some specific disease conditions where there's only one choice. But other than that, a lot of heart conditions, there are multiple choices. And it really does become important for patients to share their goals for therapy.
Right, thank you. So the next question is, what are the reliable sources and tools out there for patients to download to prepare for these discussions with their doctor?
Mm-hmm. Well, as I mentioned, the internet can be a little bit confusing. And certainly understanding who is writing certain pieces and what their focus may be on that education, I think can be challenging. So certainly going to the professional organizations like the American College of Cardiology or the American Heart Association or Mended Hearts or other patient advocacy groups are the best places to start. And in fact, I would say that I'm sure Mended Hearts is a great resource to help point people in the direction that they need to go. So Andrea, what are your thoughts about that?
Yeah, I actually agree. And it's the perfect segue to let you know that we have 2 discussion guides that are in chat right now. They're listed on our website. And we discuss shared decision making and informed consent and really how to get to that. But on a specific topic like aortic stenosis or valve disease, we have education on the website that you can get. And I suggest, if we don't have it, we always have a way to give resources to individuals from reliable sources. So, and that would go for anybody, even if they're not in the heart world. I would say patient organizations typically have the best connections to resources in their area of expertise. So the next question is, this is a good one, do doctors train on the art, which are soft skills, along with the science in US medical schools? Is this a part of the standard curriculum, or is this just something they have to learn on their own?
That is a good question. I think that what you're asking is really important. And the way that you're framing it, you understand that these are skill sets that we learn and we practice. People aren't necessarily born into the ability to translate complex information into ways that a variety of folks can understand. We do a little tiny bit of training in medical school on that. We do some, practice patient exams and maybe a couple lectures around it. But most of the training is around science and technique. So there is clearly room to go with regards to communication. I will say the other fun focus that has come up in the last 1 to 2 years is understanding how we pick who are doctors. So traditionally, we have picked in a way that's been going on for decades. And that is, we look to see where did the person go to undergraduate school? What were their grades? What were their test scores? And who did they know? And you might guess that that doesn't bring you a diverse group of people that have a variety of skill sets, like excellent patient communication skills and empathetic approaches, or even similar backgrounds to your own. So that is starting to change with regards to how we pick who's in the medical field. And I think that will be really important. We also have, we're changing a lot about who you all interact with in the office. More and more, you'll be meeting with advanced practice providers, nurse practitioners, and physician assistants. And their training is very brief. And so there is a lot that we can do through our professional organizations and patient advocacy organizations to do ongoing training for all clinicians.
Yeah, and I think it brings up an interesting point, because as a caregiver of a child who had a congenital heart disease, had open heart surgery, my first indication of, do I like this surgeon, was, is he going to save my son's life? So I wanted to know, is he really good at what he does? However, once that was over, the relationship was what kept us going back. And so I guess that there's great things to both sides. I mean, like, I didn't care that he was like a nice guy. I just wanted him to fix my son. So I think that there are both sides of that coin that people should be looking at. It's interesting. Okay, so someone else says, I don't think I've ever experienced this type of process in healthcare. What should I be doing differently as a patient?
Yeah, I think that's related to the first question in part, and whose role is it? We looked a little bit at that systematic review talking about knowledge is not power for patients. You know, that the invitation really needs to be there from their clinician. But I do think there is the opportunity to provide some input in your care and to open up the discussion around the role of shared decision-making and the role of patient preferences. Hopefully today our discussion provides some language around that. But I would highlight, it's very likely that you may meet clinicians who have not heard of this concept before or have misconceptions about what it is. So I wouldn't let that necessarily deter you or make you feel down about it. It is just the state of affairs. And boy, do I need as many advocates as I can get to, help move this field forward. But I think with regards to your role, certainly reaching out to your patient advocacy organizations and doing some of the work to learn more about your disease condition and to learn more about what was important to other patients like you can help you be more of an advocate during that conversation to articulate those things. It does take that understanding of your disease condition and what's possible to be able to give voice to it.
Yeah, thank you. So I have two questions that I'm going to kind of roll into one. I think you've already answered, how can we be sure our physician is aware and sharing all of my options? If they're not currently, this is different. If they're not currently giving all of the options are available in your hospital, in your local clinic, how do you know? And should we always get a second opinion? But the next question is, how do clinicians really feel about people getting second opinions?
Yes, that is actually, this is a really tough topic. Not only do certain hospitals only offer certain choices with regards to the treatment, but also your own insurance might offer you only, one hospital to go to. And so it's harder to figure that out. But it's true. When you go to a hospital, if they don't offer all the choices, you're not going to learn about them there. It's very rare for people to say, here is the full spectrum of options. It's something that I do frequently because I, speak a lot nationally. I'm involved in research studies. There are a number of research studies that we don't offer at my institution. There's no institution that offers every research study. So I'll tell them, here are all the options and here are the different ways that you can explore that. But I do think that that's less common. So I think simple questions like, I think there might be some new options around how to treat my condition. Can you tell me more about that? Or can you help me understand how I could find out more information about that? Would be fair. And I think that most physicians do not mind a second opinion. because what they worry more about is patients having regret about what they've gone through. So I think that it's important to welcome that input. Now, every person's different, so we can't promise that. But if you're with a physician that becomes angry at anything that you offer, then probably not the best fit for your medical care.
Right. Yeah, and I think this kind of goes along the same lines. It says, I grew up in a time where I was taught to not question authority. And so I feel uncomfortable or disloyal to my long-term doctor if I seek other views or question her. How would you suggest that I deal with my own hesitancy and become a more proactive patient? So I'm going to say in the beginning, become very empowered, educate yourself, get some empowerment tools from organizations like Mended Hearts, because really you need to be an active participating part of your healthcare team from the patient side. And then I'll let you talk from the clinician side.
Mm-hmm. I think that is hard. I mean, we even feel that way about getting our hair cut, right? I mean, you develop this relationship with someone and you want something new, but you feel bad about leaving them, let alone when it's someone who's helped take care of your health for years. But I think we just have to remember that the people that we entrust with the care of us, they want to care for us. And that includes sometimes asking for help or getting new opinions and new ideas. And that should be something that's welcomed. And if it's not, well, then we might need to start thinking about that relationship, because they really do need to have our best interests in mind, the people that are caring for us. And it's hard to keep up on every single change in what's happening in medicine. So I think it's a lot to ask one physician to know everything about everything. So I think it's reasonable to develop a team approach and ask others. Sometimes it's second opinions within the same field. Sometimes it's going to a specialist in that area. I think that is a great way to gather information. It doesn't mean you undergo a new procedure or switch doctors or get a new medicine, but you just gather more information.
Yeah, and I recently had a conversation with a doctor where I had brought up something that I had read, and we had a nice conversation about it. And he said, I had not seen that paper. I'll have to do the research on it. And so it was a great conversation, because doctors don't know everything all of the time, and then there's new things that come out. I also think it's a respect. So if we respect each other and we're having a conversation that's built around respect and not demeaning or demoralizing in any way from either side, I think we can have those conversations and it not look like we're challenging them. So this one is about the clinical trial process. If I go through the process and start the clinical trial, if I find out that I get randomized to a treatment I don't want, can I just stop the trial, or am I obligated to proceed with the treatment I don't want?
What a great question. And the answer to that is, if you're interested in a clinical trial, we really need to make sure that we're willing to be randomized to either group. Otherwise, I would not sign up for the clinical trial, because it's very important that all of the folks that are in the study understand that the truth is not known about whether this new intervention or surgery or medicine is better than whatever they're comparing to, prior medication or no medication or a different procedure. So we have to go into the study feeling like we don't know what's better. If we do know what's better, we would just offer it. And so the comparator might be better. So that's the way we need to think about going into clinical trials. And if you feel like, no, I feel for sure that this new thing is better, we can't have a guarantee that you'll be assigned to that group in a clinical trial. And if you did become randomized to that, then you just quit the trial. It's what would happen. And so we, as investigators, we don't want to have people quit the trial. We want to have people that stick with it. So there will probably be trials that you'll be offered that you'll say, you know what, thank you for asking. I just don't think I could be randomized to both groups. But before you decide that, I would engage again with the physician who's running the trial. You might learn more that encourages you to stay involved, to really understand the equipoise that we don't know which one is better. And it is so important that we have people volunteer for particularly people who have not traditionally been represented in clinical trials. So women and people of color, they've not been asked to participate. They've not been met where they are so that they can participate. They haven't seen themselves reflected in materials around clinical trials. And guess what? At the end of the clinical trial, we don't have information that pertains to those groups, which is not helpful at all. So we do want to make sure that we do everything we can to make people feel comfortable. But at the end of the day, you might decide, I just don't want to be randomized. I think this new device is the best and I don't want to not have it. That said, that's probably the only way that you'll have a chance to have that device. So at least you have a 50% chance that you would be able to have it within the trial.
Great, great information. So the next question says it's really hard to find information about clinical trials to actually be informed. Any suggestions?
Well, I guess I got stumped here at the end of the webinar. I think this is a huge area of need, and that is communicating with patients about what clinical trials are available. Part of it's hard because each clinical trial is pretty specific. You know, it's for one specific therapy. And so there's not necessarily one website that is easy to navigate where you can get right into to that particular disease condition. So I would say the best way to figure it out is to ask a doctor that specializes in that disease condition. And if they don't know, it's their job to figure it out if there are any ongoing clinical trials. So for example, I run a lot of clinical trials for stroke prevention. So you want to go to someone who really is passionate about stroke prevention and say, I want to be involved in any research studies that are out there. I have not had patients say that to me. So I think that would be a great start. And I would be really excited about that. So probably going to the physicians. There's not necessarily a website, as we have spoken about in past webinars. Clinicaltrials.gov is not designed for patients to be able to navigate through, so it can be difficult. So I think continuing the conversation, that respectful back and forth conversation with your physician is the best way to learn more about clinical trials as well.
That's a great suggestion. I know clinicaltrials.gov is very hard to navigate. And then I think also as a patient, if you get there and you find a trial, understanding the trial, the way it's written on there is kind of hard as well. So talking with your doctors and trying to see what they know and have them understand it and then explain it to you might be the best way. That's a good one. So is there an official rating system or Yelp for doctors that is a good way to find a specialist? That's a good question.
Well, I don't know if you have an answer to that, Andrea. I will say one caveat about ratings. We do get rated through, there's some specific surveys, the CAPS survey, for example, that are rated by patients. But I think that I wish there was an answer to find out what would be a best match, almost like when you're getting a roommate or something, if you like the same things or we don't have anything like that. And in fact, some of our current rating systems are intrinsically biased. And so traditionally, the physicians that are ranked the highest are those that look like traditional physicians. White, older, attractive, well-spoken men over perhaps a lesbian woman or an African-American man from the community or an Asian physician. Or an older woman. And so unfortunately, there's been research that has shown that the rating systems tend to be biased, where even patients don't realize they're rating them on some of the traditional stereotypes about physicians. In addition, it can be hard to know, as Andrea said, about their clinical outcomes. So have you met a physician where they didn't have everybody say, oh, this is the best physician in town? I mean, that's just kind of a thing we say about doctors, about people who do procedures. So there is an increasing focus on public reporting of outcomes. Usually it's from a hospital side and not necessarily from a physician side. So I do think that this is another area, just like finding out information about clinical trials, finding out the characteristics of physicians that would be a best match. We certainly ask our family and friends, and we ask other physicians, but I think ultimately it's going to your physician and doing just what you all suggested. I'm interested in a relationship where we can do shared decision-making. Is that something you're interested in? And that would be a great start to finding a physician that would be a good match.
Yeah, and I think, along the lines, Mended Hearts and probably a lot of other organizations, we steer clear of recommending specific hospitals or doctors, or because what we find is that in the patient population, you have patients who will love a hospital or a doctor, and then you have patients who don't. It does boil down to patient preference, I think. When we talk about outcomes and clinical outcomes, surgery outcomes, we also try to allow patients to understand that just because somebody has a lower success rate does not mean they're not a great surgeon. That might mean they're taking on the highest risk cases because they're really good, but they're having worse outcome because they're seeing these patients who nobody else could save. So I think that it's very tricky to rely on a rating scale to rate a doctor or a hospital because everybody has their own opinions. It's really difficult to do that. So I don't even know if a Yelp would be great at that. That's, you know, I think we all get stuck in that though. Like, I need to see a 5-star rating for this doctor. But I would steer clear of something of that nature myself. So I think we have time for one more question. And it says, I would be willing to travel far for a trial. If you live really far away from a hospital, can you participate and get treated and then do things like follow-ups virtually or telehealth or anything like that so that more people have access?
The answer to that is yes. And it's expanded even more after COVID. Now, the institutions that run clinical trials, really, its follow-up is essential in order to understand the outcomes. But if people are traveling from a far distance and they have a cardiologist that can communicate those findings and make sure to do all the surveys and whatever is required from the trial, then you can do that closer to home. So that's something worth exploring. And if you find an institution that is running clinical trials and has one that you're interested in, they will have a study coordinator, and that person will be accessible by phone. And so you can talk about your interest, find out if you meet the inclusion exclusion criteria, and whether an initial visit is even worth it. And then talk about upfront what the options are for follow-up. So I would not limit your thought process about participating just from those hospitals in your region, because there are many regions that are underserved with regards to clinical trials.
And we'll just end with the final note that says, thank you, Dr. Megan. I wish I lived near you where there were more doctors like you in my area. So with that,
thank you.
We'll be done. And I just want to thank everybody. Remind you again, there are a couple of discussion guides in the chat that you can download. We will have a recording of this webinar as well as the downloadable documents on our website following the event. And anybody who was registered will get the recording sent out to them. So Dr. Kohlwright, thank you so much for spending the hour with us. We appreciate it. And thank you everyone for joining.
Thank you. Take care.
Bye-bye.